PhD. Dr. Eluri, it's all yours. Take it away.
Thank you so much for that, Mona. So today we're going to be talking about understanding autism and its community resources and how that interplays with psychological and neuropsychological assessments. We will try to request that people put any questions that they have in the chat, and then we can either address them as they come along or towards the end of the presentation. So when we get started, I'm going to just list a couple of agenda items so that we can kind of stay on track. I'm going to briefly define what autism spectrum disorder is and what the characteristics of autism spectrum disorder are, namely because there are a lot of them, and this doesn't typically fall in the same presentation as a lot of other psychological or psychiatric disorders. And then we'll cover psychological and neuropsychological assessments and how those help us get to really understanding and fine-tuning differential diagnoses as it relates to autism, but also other potential concerns or diagnoses. And then we'll continue with discussing differential diagnoses and then discuss available treatments and community resources. So just to kind of get started, when we look at what autism spectrum disorder is, it's actually a neurodevelopmental disorder characterized by certain things. So the first one is a deficit in social emotional reciprocity. When we talk about deficits in social emotional reciprocity, we'll go into that in a lot of detail because that seems to be one of the hallmarks of an autism spectrum disorder that typically defines the disorder and differentiates it from other disorders. We will also look at deficits in nonverbal communicative behaviors used for social interaction. And then also that there are deficits in understanding, maintaining, and developing relationships. Again, all of these tend to fall under the bigger heading of social communication or social interaction deficits. And this may look different for lots of different types of individuals. And it looks different at different developmental stages and with different language levels. And so we'll talk a little bit about that. The other category is that they tend to have restricted or repetitive behaviors, interests, or activities, and they tend to have at least two different categories. So they may have stereotyped or repetitive motor movements, objects, or speech. They may have some insistence on sameness or tend to be very inflexible, tend to have very ritualized patterns of either verbal behavior or nonverbal behavior. They also tend to have restricted and fixated interests that are abnormal in intensity. And this is actually one that tends to confuse a lot of providers because we also see this in a lot of other types of diagnoses, namely gifted children or children with like obsessive compulsive disorder. And then there's also the hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. And so these are the broad kind of definitions, but as we kind of boil some of this down, we really want to make sure that we kind of classify it in a lot of different ways. And this is required for diagnostic purposes. So one of the specifiers that we will talk about that also tends to kind of make the presentation hard to identify is that some children will have an intellectual impairment, others will not. Some children will be neurotypical, other children will not. And that actually changes their, the way that they present externally to providers. Also, it changes the way they present to their parents or to other caregivers. Based on whether or not they have an intellectual impairment, what we often see is that if they do have a severe intellectual impairment, then they require higher levels of support. So diagnostically, sometimes what you'll see is, you know, in autism spectrum disorder, and then it'll be considered a level 1, meaning that they do require some support, level 2, some substantial support, or level 3, which is the most serious, and it requires very substantial support. Another specifier, again, which tends to confuse the diagnostic presentation, is that some children who will get a diagnosis of an autism spectrum disorder will have a language impairment, others will not. And so their language actually develops on time. They're not delayed or behind their peers, but there is oftentimes something unusual about their language. Either it's robotic, it's stereotyped, it's overly structured, it's extremely advanced. So we really do need to fine tune what is going on with their language. And then you'll see that oftentimes in the diagnostic specifier as whether or not they do have a language impairment. And then the last one is a specifier if there's a comorbid medical or genetic condition that is the cause of autism. So there are certain things like Down syndrome, there are certain genetic abnormalities that tend to occur that lead to the presentation of an autism spectrum disorder. And then the last piece is that some children, this tends to be a little bit more rare as far as the range of individuals that I have seen, but some children will present with what we consider catatonia, very low mobile abilities. They will either be very slowed in their ability to kind of navigate their environment. They will be seated most of the time, or they will have abnormal body movements that will be restricted in a certain place, such as like posturing. So they'll have an abnormal posture and they'll stay there for an extended period of time. And so we'll kind of talk a little bit about what this looks like, because the presentation again varies because there are so many specifiers within the autism spectrum disorder. One other thing to note about autism spectrum disorder is that prior to 2013, there were two diagnostic categories. So the initial category was an autism spectrum disorder, but the higher functioning, so the kids without an intellectual impairment and the kids that didn't have language impairments tended to fall in another category called Asperger's. But with the onset of the new DSM, they've combined those categories and they've brought into the criteria for an autism spectrum disorder. So when we're looking at some characteristics of autism spectrum disorder, namely in the social communication, let me see if I can go back a little bit. Oh, there we go. So some of the things that we tend to look for when we're looking at the social communication interaction deficits are that there is either delayed or abnormal speech. This may include things like a pronoun reversal, so referring to a man as she, referring to a woman as he. This often takes the form for children. They will talk about their parents as, look at my daddy. This is Mr. Daddy. So their speech, although not incorrect, is not socially appropriate. So as for an introduction of a father figure, they should say, you know, here's my dad, but it sounds abnormal. The other thing that we often look at is intonation, volume, rhythm, and pitch. So if one of those things or any of those things are off, we often consider the possibility of an autism spectrum disorder. Some individuals will sound robotic, very mechanical in their speech. Others will have slow and halting speech, while others will have very rapid speech, almost pressured. And then the other thing that we look at is volume. So sometimes they're just everyday natural speech is very loud. Parents will describe that a lot to me, or very quiet that you almost need to constantly ask them to repeat themselves so that you can hear them. The other thing that we often see is that some individuals will struggle with initiating, maintaining, or ending conversations, which due to the struggle with initiating, maintaining, and ending the conversation, it leads to further struggles in making friendships and developing relationships. This tends to be very confusing for parents because depending on what your goals are for your child, you may not necessarily want them to have a lot of friendships, or you may not want them to be overly social. And so you may not, kind of reinforce that or encourage those types of behaviors. But there is a striking difference between someone who is more academically inclined and someone who just cannot do it. And this difference is really in their ability to kind of maintain those relationships and care enough about people. Sometimes you can see this in the parent-child relationship. So parents will say often that they don't feel connected to their child, or they don't feel like their child is connected to them, or that the way that they connect with their child is abnormal in presentation. Another thing that we tend to look for is their ability or their struggles with shifting their behaviors to the social context. Meaning, for example, the types of things that people like to do at home may not necessarily be socially appropriate in a bigger group setting or in an outing. And if they cannot kind of identify what external kind of stimuli are in the environment to shift the dynamic and then alter their behavior accordingly, that means that they're not socially aware of the differences. This often tends to present in families with parents being very concerned about their child eating in public. So they'll be able to eat at home, they have certain foods that they'll eat, but then they won't be able to order food at a restaurant, for example. So that's one of the most common examples that I tend to give, and they just can't shift that behavior out. There also tends to be just a little, and this doesn't happen with all kids, but there tends to be very little interest in interacting with peers. Or they tend to misunderstand the relationships of others. So one thing that tends to come up often in the clinic is that they will call people who are just random people that they've met very close friends, or even though they've only met them once, they don't know much about them and they don't have very many interactions with them. This often tends to be like a neighbor or a teacher in a different classroom, and they will refer to them as a friend, misunderstanding the dynamic of what a true friendship means and what it looks like to be a friend with somebody else. And then one of the other category that we had mentioned earlier was this idea of restricted and repetitive behaviors. This often is in individuals who require a lot of support, who end up with a diagnosis of autism spectrum disorder, is often very clear. They tend to have repetitive play. They tend to play with parts of objects as opposed to the whole thing. So instead of playing with a car and racing it around a room, they may just spin the wheels. However, in higher functioning individuals, this actually looks a little bit different, and I'll try to kind of highlight some of the differences that we'll see. In higher functioning children who don't require a lot of support, they tend to have rigidities with food. There's often another diagnostic criteria that tends to co-occur, which is avoidant and restricted food intake disorder. And it's what we, individually, or parents will often mention, very picky eating. So they will only eat, red foods or white foods, or they can't have foods touching each other on a plate. This can flag us for a possibility of other disorders like an eating disorder or just straight avoidant and restricted food intake disorder, or possibly an obsessive compulsive disorder around eating. However, if we look at it under the bigger umbrella of social and communication deficits, then we start to consider the possibility of an autism spectrum disorder at play. Other things that we'll see, although this is not necessarily required, is hand flapping or unusual posturing. Again, this can lead to possible catatonia if it's a severe case, or a possible tic disorder. I will often get referrals for concerns related to tic disorders, when in fact it actually ends up being an autism spectrum presentation. There also tends to be some fixated and unusual interests, often in the sensory domain. However, this is not always the case. And what this looks like is more that the child cannot shift their interest to talk about what other people are interested in. So for example, I had a very high functioning young man come into my office, and he was only interested in dinosaurs. And anytime I tried to shift the topic away from dinosaurs, he would bring it right back to dinosaurs. This is very different from someone who's just very excited or interested in a topic. What that would look like is, they're interested in dinosaurs and they have this higher level cognitive ability. And then what we see is they can then, if I mention my dissertation, for example, then they can kind of shift and talk about that. And that's typically not what we see. If someone has an autism spectrum disorder, they really want to keep going back to their original fixated interests. There also is the possibility for self-injury. So hand biting, head hitting, head banging, and pinching, self-pinching, pinching other people. And so we often take a look at that. Individuals with autism, or who end up with the diagnosis of autism, also line up toys or objects. And they may have repetitive speech, either their own speech, or they may repeat speech of others. And this one tends to be kind of confusing for parents. It's something that I get a lot of questions about. They will talk about it as if their memory is really great, which is great. That is actually true. Individuals with autism tend to have strong memories. But they will be repeating movies or lines from movies over and over and over again. And that kind of is the restricted and repetitiveness that we're looking for a possible diagnosis of autism spectrum disorder. And now that we've got a really good kind of understanding of some of the things that we're looking for when we're considering a possibility of autism spectrum disorder, I'm going to shift gears now and talk about psychological and neuropsychological assessment. In part because psychological and neuropsychological assessment is the means through which you would get a diagnosis in the field of psychology. Some psychiatrists and some neurologists will also provide a diagnosis. However, there tends to be a lean, at least in the insurance domain, with specific testing that needs to be implemented in order to provide a diagnosis of autism spectrum disorder. And this is up for debate for sure across different professions, but it is something that oftentimes to get access to services under an autism spectrum disorder presentation or diagnosis, you would need to go through an assessment process. So I'm going to walk through some of the steps here on what that looks like, and then we can kind of delve into that in more detail. So the first part of that assessment is really kind of looking at cognitive functioning. And I know it sounds kind of counterintuitive that we would do this, but given that the diagnosis of autism spectrum disorder, if it's something that we are concerned about, or parents have brought up some concerns and we think, hey, it might be autism spectrum disorder, we really need a good gauge of where are they functioning at, because this will help us kind of understand what treatments are appropriate for them, and then also what the best route is and what the possible outcomes are. Now, we can't do that with certainty all the time, but oftentimes, if the child is about 6, we will often do a cognitive functioning battery of assessments. We're also using it to rule out other possibilities that may present like autism. So giftedness is the main one. Individuals who tend to be gifted will have some more restricted and fixated interests, but they can shift those interests when bringing up other topics. They also tend to engage in some repetitive behaviors, some repetitive studying, repetitive reading. They may be hyper-focused on certain things. So we really do want to get a good cognitive battery so we can at least understand what level of functioning they're at, what possible outcomes are, or if there's a different type of presentation here that we need to be looking at. The other concern here is that we can use the detailed information to identify a pattern of strengths and weaknesses for treatment purposes for the individual. So, for example, if there is no speech impairment and they really understand what other people are saying and they can communicate back with their caregivers and with their peers, they may have higher verbal comprehension scores and they may not need speech services, for example, whereas they may need some support with visual spatial skills. They may need some support with kind of thinking outside the box or problem solving. And so that will really help us better understand what types of services are going to be appropriate for that specific individual. The next thing we're going to look at is executive functioning. And this is interesting because most of the time when people think of autism spectrum disorder, they don't necessarily think of concerns with executive functioning. However, when you spend a lot of time with someone who has autism spectrum disorder, the concern is, is this really that they're not paying attention? And that leads into concerns with attention, concentration, focus, and then any response control. And so we really want to get a good measure of what their executive functioning processes look like. We do this either through performance-based measures. These are usually computerized assessments, or we will do this through parent and caregiver questionnaires if they're not old enough to be able to complete the performance-based assessments. And we're really looking at attention and concentration and seeing if those are intact. We're also looking at their ability to control their own responses and determine whether or not those are intact. Their ability to shift their attention to relevant information, which is really important in being able to learn new information. We are also looking at initiating, monitoring, and completing tasks. So this is specifically more important for the academic environment. So if we're trying to make decisions about, do they need 40 hours of intensive therapy or do they need to go to school? If they can initiate, monitor, and complete tasks, then we often recommend an academic environment. And also if they can plan and organize their materials. The next piece is a social functioning kind of assessment, and we do lots of different assessments. The first is we often give out questionnaires. Many of you guys may be familiar with these types of questionnaires. The MCHAT is the one that's the most commonly used in pediatricians' offices. But there's also a social communication questionnaire and a social responsiveness scale. And these are often referred to as screeners. They often are not required by insurance, and they are not diagnostic, meaning insurance, even if you just did, for example, an MCHAT, insurance will not believe that that's sufficient data in order to justify a diagnosis of autism spectrum disorder, and they'll often send it back to the provider. So they've really started to require higher levels of assessment and more detailed assessments. They require that the assessments are done either in person or via telehealth with a monitor. And the most commonly used one is the ADOS, which is a play-based measure. This measure is very structured and systematically used to place and observe social interactions with the individual through developmentally appropriate social bids. And what this actually looks like is a child walks into a room full of play materials, if it's a younger child, and their language is, either single word or phrase speech. And it's a room full of toys, and the examiner will interact with the child to evaluate their social responses. These are very structured and very organized, and so the child needs to score a certain level in order to meet criteria for autism or not. Also, there are certain skills and activities that tend to vary based on the language level of the client. This is really important because the ADOS really requires that you're providing developmentally appropriate social bids. And that means that if they cannot kind of interact with you and have a back and forth conversation with you, let's say for an 18-month-old, then really what we're looking at, it needs to be developmentally appropriate. And so the items actually change and the activities change. And so often this is what insurance will require. There are other measures like what we call a CARS or an ADIR, which are assessment measures that often require an interview with the parents and a behavioral observation from a provider. The next type of assessment that we'll do is an adaptive functioning assessment. And this is really important because based on the DSM criteria for diagnosing an autism spectrum disorder, there are questionnaires that are given to parents to see how the child is functioning in their everyday life. If they are up to par, meaning they are developmentally within range, then the concern about an autism spectrum disorder tends to be lower because they are able to meet their developmental milestones, they're able to go to school, and they're kind of where they need to be. However, if they tend to fall behind in either communication, social skills, daily living skills, or in motor skills, then it does flag us for other concerns. So for example, if they fall behind in their motor skills, then we know that that's a recommendation for OT. If they fall behind in their daily living skills, like toothbrushing, hairbrushing, taking regular showers, toilet training is one of our first indicators. They tend to be very slow with toilet training. So those are different concerns that are targeted for intervention. And then we also just want to make sure, and this is more broad, we want to do several different questionnaires about looking at the individual's behavioral and emotional functioning. Sometimes these are completed by parents on behalf of the child. Sometimes these are completed by the child themselves. And we're also looking at whether or not there are other possible mental health conditions that could explain the presentation. For example, social anxiety tends to lead to, poor social relationships because the child is very, very anxious. It doesn't necessarily mean they have autism, but their relationships are really kind of impaired. And then we really not want to think about or not provide a diagnosis of autism, but really, think about, okay, we need some treatment around anxiety, and this is really in the mental health field, and they need therapy. The other thing that we often see is depression. They tend to have psychomotor retardation, meaning they have slowed psychomotor skills. There tends to be an abrupt onset. There tends to be some pickiness with eating. There also tends to be problems with concentration and interference in social interactions. We also see a lot of selective mutism. This is something that is very rarely diagnosed, at least from what we tend to see, but using some of those questionnaires to really understand, okay, are they communicating with parents at home, in other settings, and are they just not communicating in session? That's really important. And then also we want to look at other possibilities. So ADHD, for example, if the struggles with executive functioning are significant, then that's something we're considering. And then also oppositional defiant disorder, if they are refusing to comply with demands by parents, even basic ones. So the next step is we do these assessments and we really are trying to tease apart, okay, so what what are we looking at and what does the information tell us? And this leads us to differential diagnoses. And when we do that, we're really looking at a range of different disorders. And I've listed a couple of them on this slide, but what this tells us is that oftentimes when people are coming in either directly for an autism spectrum disorder evaluation, or if they're coming in because of something else, we're really trying to tease apart through our long neuropsych battery, is it just an intellectual disability? Are they gifted? And those have their own presentations. We want to know if the social piece is impaired. Often gifted individuals really struggle with social skills, not because they're incapable of initiating, maintaining, and ending social interactions, but they really just don't have normative peers who are at the same intellectual level. And so it becomes a struggle for them to interact. The same is true on the other end of the spectrum. If they do have an intellectual disability, then they may not be completely understanding what their peers are saying, and so they may struggle socially. We also look at ADHD if they are having a hard time attending, concentrating, paying attention to their peers, or they have so many behavioral excesses, they're jumpy and jittery. Then that can interfere with social dynamics. I will often have individuals come in who just have a severe case of ADHD, and the main concern is that they're having a hard time keeping friends because friends find them too intense. There's also the possibility of a social communication disorder, and this is really, I often tend to think of this as autism without any restricted or repetitive behaviors. So there's no real hand flapping. They don't have any restricted interests. They're just kind of awkward socially, and they're not picky eaters. They're not engaging in repetitive behaviors. And so it's just that really like social communication piece that's been a struggle. And that often has individuals referred for social skills, either training or social skills support in a therapeutic setting. There's also a developmental coordination disorder, which is almost the reverse of a social communication disorder. If we look at it through the lens of an autism spectrum disorder, a developmental coordination disorder is where there are some motor issues, but the social communication piece is intact, meaning that they will have restricted or repetitive behaviors. But that's essentially it. They will have some odd posturing, they will do some hand flapping, but they're not necessarily at the level of a social communication disorder. It's not interfering with them socially. We've mentioned selective mutism. There's also tic disorders. Obsessive compulsive disorder tends to be a big one. Prior to the development of the ADOS, which has been really good and is considered the gold standard for diagnosing autism spectrum disorder, a lot of individuals who had high functioning autism or Asperger's disorder were receiving a diagnosis of obsessive compulsive disorder due to things like picky eating, hand flapping, repetitive movements, things like that. And then there's also the possibility either together with an autism spectrum disorder or as separate mood disorders like depression, bipolar we'll often see. Also anxiety disorders, namely social anxiety. There are also language disorders like stuttering or a mixed receptive and expressive language disorder. That's something also that we can look for. And a fluency disorder or a speech delay, just purely a speech delay without some of the social communication struggles. And so when we think about the range of possibilities that tend to be consistent with an autism spectrum disorder or tend to have an individual referred for autism spectrum disorder, what we tend to look at is that there are a lot of treatments available and there are a lot of different supports. One of the things that we want to make sure that we do is that we tie our treatment specific to the presentation of that child. And so oftentimes what happens is some people will just put a blanket statement like, they need ABA. this tends to backfire, especially because there's a lot of backlash within the field of ABA right now, surrounding issues like consent and things like that. And I caution you to, to consider other possibilities, because individuals who tend to be on the higher functioning end of the spectrum also tend to have very concrete thinking and are very inflexible as part of the diagnostic criteria for an autism spectrum disorder. And so really what they need, instead of a highly structured ABA program, is that they're able to learn pretty quickly. And ABA is known for its repetition in order to build skills. And so when we think about that, sometimes I will recommend for higher functioning individuals with an autism spectrum disorder to consider therapy. This therapy is often either cognitive behavioral in nature, in order to get at their high intellect capabilities and have them think about things logically, as opposed to, having them think about things at an emotional level. And that may be enough to support them. This also comes into play when parents have concerns about things like, academics. They want to make sure they meet their child's intellectual needs. And if they tend to be gifted, for example, or tend to be very high functioning cognitively, then we don't want them to kind of miss out on a lot of school just to get ABA therapy. That can also be incredibly frustrating and lead to other issues, which we can talk about at the end of the presentation if you guys have some questions. The other thing that we see is some higher functioning individuals do not need speech therapy because their speech, for the most part, is intact. It just tends to have an abnormal volume or intonation or rhythm to it. But it doesn't necessarily interfere with their ability to communicate their wants and their needs to their caregivers or communicate socially. This is also important when thinking about parents' time and the times that they have available. If they have a child who does have autism spectrum disorder and they need a range of services, then we need to counterbalance that with parents' ability to kind of navigate all of the different services that they need. And we really want to prioritize what's most important for the family at that time for their specific child. There is, of course, applied behavior analysis, and this is really important for children who are identified early. And they may need it throughout their lifespan, but if they're identified early, what we can see is that we can kind of get them up to speed with their daily living skills, with their social skills, and with their communication skills. And that's really important for them to be able to communicate their wants and their needs to their parents. As far as, just that they're hungry or that they're tired and things like that, their basic needs. So ABA is really good at that. They also do a really great job with things like toilet training and severe behavior management. So if there's a lot of aggression, things like that, they do a good job with that. And then there's also social skills training. Sometimes, especially for the higher functioning individuals, if the main concern is that they're struggling to make friends, oftentimes I will not recommend ABA as a package deal. I will recommend social skills training, either through therapy or through, group types of therapy where everyone has a different type of diagnostic presentation. So they get exposure in a safe setting. And then, as I mentioned, psychotherapy is tied directly into that. Also, if there are individuals who have ADHD, who have low frustration tolerance or depression or anxiety, those are things that therapists are really good at treating. And then the concerns around medication, if there are severe behavior disorders or if there are executive functioning problems, then, medication is really important to support those needs. And just to kind of go through, I think we've talked a little bit about all of this already, but there are so many different types of providers that individuals with an autism spectrum disorder are going to need. And one of the things that we tend to be faced with are parents telling us, I can't do 40 hours of ABA and have them in school full time and, go to speech and OT. And so all of those types of things, we really need to be careful. One of the things that I do recommend is, medication management. If there are some severe things like self-injury, executive functioning problems, aggression, things like that. The other thing that I often recommend is that therapy is going to be important. There are some therapists who are very familiar with working with individuals who have an autism spectrum disorder, and there are some therapists who are not, and really making sure that the providers know what they want, what the family wants, and what the child needs, or the adults if they're older, that we can provide that. And then speech and OT to help with obviously language and communication and motor skills. And then we often interact with pediatricians because they're on the front lines and they really identify problems early in childhood. And they are the first ones to really kind of refer for a full assessment in order to determine whether or not an autism spectrum disorder is probably what the concern is. And that's it. I'm not sure if anyone else is here, but we could do some questions. If anyone has any questions, I'd be more than happy to answer them.
Thank you so much, Doctor. That was quite an informative and very kind of well-encompassing presentation. And I do have a couple of questions. We don't have any other participants, but as you were going through, I wrote down some things that parents of children exhibiting the characteristics that you mentioned may have. One of my first questions was, when can some of these characteristics age-wise start in children, and what are one of the first indicators, if any? So as a parent, what am I looking for?
That's a really good question. As a parent, oftentimes parents' concerns tend to get dismissed because parents tend to notice really early on, especially mothers who spend considerable time with their child tend to notice really early on that maybe something is not right. So oftentimes the pediatricians will refer them for services at about 18 months. And there's a reason for that. They often want to make sure that their motor milestones are hit at 12 months. They give some leeway, 12 to 14 months. And then if by 14 months they're not making progress, then they will refer at about 18 months. So that's pretty much like the earliest that we can tell. I have seen some babies at 17 months and I've been able to accurately diagnose, but that's a very specific criteria and you need a specialist to be able to do that. But moms actually often say, you know, I've been concerned all along. So the things that moms can kind of look out for are things like eye contact, you know, like if you're nursing or if you are holding your baby and feeding your baby, is your baby looking up at you and at your eyes? One of the early, and this is kind of brand spanking new research, but they did do some eye tracking with infants and they said that some of those early signs are evident by 6 months for an autism spectrum disorder. And that's the connection piece that parents are saying they're not able to develop. So they look for eye contact and they look for that reciprocal social smile. So if you're like holding your baby and you're smiling at them, are they smiling back at you just because you're smiling at them? And that's the kind of unspoken social language that tends to happen between a parent and a child. So those are the early signs. And that's often when parents are like, oh no, I'm concerned, or I'm not concerned, you know, things have been moving along. But the markers that pediatricians often look for are speech. So if speech is delayed after, 12 to 14 months, then they will often refer for speech therapy. And then the walking. So if children are not walking between 12 and 14 months, then their next checkup will be at about 18 months. And then pediatricians will refer.
Thank you. My next question is that there's a lot of stigma surrounding this diagnosis, as you can well imagine. And I want you to speak to the parents who do have that stigma. If they're the ones doing something wrong, did they do something not right with their kids as they were developing? Are they the cause of this? And could they have prevented it somehow?
You know, that's a really important point. And I know that I didn't spend a lot of time during the presentation talking about this, but autism at this point in time, the causes of autism have not necessarily been identified. What the general population tends to believe has happened with the increased rates of autism spectrum disorder is just better at diagnostics. And so what we often see is that parents will engage in this like self-blaming and think that they have done something wrong. But the realities are that there have for centuries been individuals who have had these presentations. And so it's not that there's anything wrong. It's just that it's a genetic situation that has occurred and that oftentimes will present with these characteristics. Even though somebody may have a child with autism, I know that that diagnosis does feel kind of heavy, but oftentimes there is a lot of significant improvement, and it doesn't necessarily mean that anyone's to blame in the situation. It just means that they're going to have some struggles, and like all humans, we all have struggles. The struggles may look different, but we all have them. And so individuals with autism can learn certain skill sets. They can learn to have a job. They can learn to, you know, support themselves. And so really kind of identifying their strengths is really where we can kind of capitalize on what they can kind of offer the world, and then also, you know, where they can kind of shine in their own life as they age. So no, I don't think that there's anything that parents can do or have done. One thing that is often recommended is that parents, you know, if they have significant concerns, that they get a diagnosis as soon as possible, because we do know that as a result of early brain development, that the brain is much more plastic. And so access to early intervention services helps you work to rewire the brain neurologically and try to make some of these things easier for the children.
Thank you. A couple more questions. When is it too late to get help for a child who's exhibiting these characteristics? If my child is 6 years old, 7 years old, and I finally see some of these characteristics and symptoms emerge, am I too late to get them the help they need?
I like to say that you're never too late for getting treatment and getting a diagnosis of an autism spectrum disorder. Oftentimes parents try to do it earlier because there are a lot of benefits. First one is early access to early intervention services. But you're never really too late. One of the concerns that we often see with parents is that they come so late that now they've got to make some really hard decisions. And oftentimes those hard decisions are when the children are teenagers and they're exhibiting severe behavior problems, meaning aggression, self-injury, elopement, so running away from the house, being a danger to themselves or to others, then this kind of flags, you know, the kind of government system like Child Protective Services, and, you know, is it safe for you to keep your child in your home? And so oftentimes that tends to be kind of like the last straw for people, because not only is it dangerous and scary and problematic, but you know, as children age, you can kind of deal with some of the behavior disorders that come along with autism, like aggression, right? You know, if your 2-year-old hits you, it's not a big deal. If your 15-year-old hits you, then it's a much bigger problem. And so that tends to be the line. So we always say that the earlier, the better, so that we can treat some of that stuff early on. I do have some experience in severe behavior disorders. It used to be my specialty. And the concern is that oftentimes it gets to a point where it's just too dangerous to keep your child in the home with you. So if you see the early signs, you want to get them treated as soon as possible.
Thank you. Last question that I have is, what are the first steps for parents to take when they notice certain characteristics or behaviors in their child?
That's a good question. I think one of the things that I would say as a parent myself, these are kind of the steps that I would take, although this is not necessarily the formal process, but I would really get a good gauge from my child's teachers or other individuals who work with my child, like a daycare provider. And I would start asking the questions, are they talking? Are they, walking if they're at that age? Are they interacting with their friends? Are they playing? And oftentimes, daycare providers and teachers are the first ones to notice if parents just are so unfamiliar with, if it's their first child, for example, and they don't really know what to expect. That tends to happen a lot. Then, teachers and getting other people's perspectives. The other thing that I would do as a parent is I would also kind of start watching same aged kids. So I would try to volunteer at the child's educational placement, in their daycare, preschool, just so that I could see what is going on and see if my child fits in. So that's what I would do as from a parent to a parent. Professionally though, however, I think the next steps are you really ready to get the support you need and reach out to somebody who can do an assessment? And this is really important because, there are people who will do assessments, but you also need to be ready for what you're about to hear. And I think that, as you had mentioned earlier, there's a lot of stigma around this. And, if you get a diagnosis of autism, how is that going to impact your family? And, are you really ready to hear it? And then are you really ready to kind of start getting involved in getting access to services? And so that would be my next step after kind of doing my own informal kind of investigation, talking with their teachers or providers. I would then kind of call to see if there's someone who can do an assessment.
Thank you so much. I feel like you gave us a really kind of 360-degree view of what goes on with this diagnosis, and each and every step of the way, what tools are used in order to reach this diagnosis and determine the kind of help that every child needs. Is there any other information out there that you'd like parents to know, or even providers to know, when it comes to this diagnosis? What are some things maybe you've noticed out in the field that often go unspoken or often go unaddressed?
Yeah, I think one of the things that's really important, well, there's two things. The first is that the reason a diagnosis early on is important is not because people want to stigmatize you or anything, but it actually unlocks the doors to get access to certain services through insurance. So that's really important, especially because costs related to getting access to early intervention are very expensive, and they tend to skyrocket. And so the importance of that early intervention is really to kind of, again, go to my next point, is to ensure that your children are being safe and being protected and being able to live to their fullest potential. And so oftentimes parents have that concern, like I don't want them to have a title. I don't want them to be stigmatized. I can deal with it. And at 5, for example, you can deal with aggression. But if you're starting to see those types of behaviors like aggression, self-injury, elopement, things that can be dangerous, destroying the room, destroying your house, that kind of a thing, then those are early signs that they want to communicate with you and they just don't know how. And so really, I would try to encourage parents to get access to services for that reason, so that things don't end up, the child doesn't get bigger and is less able to cope with their thoughts, their feelings, and their emotions without being able to effectively communicate with you. And so those are my biggest kind of points on that.
Thank you, doctor, so much. Really good topic, often goes untalked about. So thank you for bringing it to our attention and addressing it and talking about it here today. I am very, very appreciative. And I hope we can do this again and have a bigger group of people that you can speak to. Yeah, and that's it. I really appreciate you.
Well, thank you so much for having me. And it was wonderful being able to present to everyone. If there are other people that do see this presentation later and they have some follow-up questions, I'm going to go ahead and just put up my contact information, and you can send an email to my office, and then we'll be able to try to respond to as many of those as possible. Okay.
Great, thank you. I'll leave this up maybe for another